Hi, everyone. I recognize some faces from the first session of the day, so I'm happy that you guys have made it to all these panels. My name is Rachel Friedlander. I'm a first-year medical student at Weill Cornell Medicine. I'll be fielding your questions, but for right now, I'm going to turn it over to our moderators who are going to introduce themselves and a little bit about their specialty, and then we'll have time for your questions.
Good afternoon. Thank you very much for being here today. Thank you for the organizers and our moderator, and my colleagues, Dr. Susan Broner and Dr. Heather Goodman. My name is Anna Kreiger. I'm a sleep specialist, and I'm the medical director of the Center for Sleep Medicine at Weill Cornell Medicine. One of the questions that I get asked more often is, what is a sleep specialist? So I'll tell you a little bit of what we are. We have a variety of people that can practice sleep medicine. Some are clinical psychologists, sometimes they're nurse practitioners, but the majority of us are physicians that were trained in different medical specialties. And what unifies us is the training in sleep medicine. Sometimes you could see a doctor that is a sleep specialist whose background may be in pediatrics, in psychiatry, neurology, internal medicine, geriatrics. Even ENT surgeons, which are otolaryngologists, they can be trained in sleep medicine. So it's always important to also ask them, because what this allows you to do is just to understand what in your particular sleep disturbance are they best fit to treat your condition. With that, I would just ask you to keep in mind that everybody undergoes the same training. So we're all trained to address all sleep problems. So what are sleep problems? The big one that we always see in the media is sleep apnea. Sleep apnea is not necessarily a disease only of men, although it's much more commonly seen in men. For women, it tends to become more of a problem after menopause. So it's important for us to keep in mind that even if we're not overweight, which is a major risk factor for men, women can develop sleep apnea. Even if you don't snore at night, sleep apnea may be present, because sleep apnea might be intermittent. So instead of having a disturbance, which means as you fall asleep, the airway gets narrowed, and you have more difficulty breathing, which you might not even perceive, the amount of air that you take on each breath decreases as the night goes on, which may lead to changes and drops in oxygen levels. And that's our major concern about sleep apnea. It's the factor that you might not have enough oxygen circulating for adequate brain health or cardiovascular health. Another problem is that in order to normalize our breathings, then we tend to wake up in the middle of the night. And that's the period that we can have more of a surge in blood pressure, and people may feel more of adrenaline. Sometimes people describe as a little bit of a palpitation sensation or anxiety sensation at night. Now, besides sleep apnea, there are many other problems that we tend to treat. Insomnia or sleep difficulties is a big one, very, very prevalent. People having, particularly women, and we're talking just before this discussion, living in a busy city, having a busy life, a lot of environmental challenges, noise, air pollution, a lot of light coming through the apartments. We might not be able to fall asleep very effectively or sleep well during the night. Another disturbances that we treat overlap a lot with our two moderators related to movement disorders at night, sometimes restlessness, sometimes people may act out dreams, sometimes they have difficulty focusing on a phase of sleep, which means you may have a irregular sleep schedule, which may be self-imposed or professionally imposed or because of your personal life. And sometimes a lot of anxiety and mood disturbances, they can trigger sleep disorders, or it could be the opposite. So we can go both ways. So sharing a panel with neurologists and a child with psychiatrists, right, will allow us to address all those issues and try to address issues that you might have more specifically with this multidisciplinary point of view. Thank you.
Hi, my name is Susan Broner, and I am a neurologist, and I specialize in headache disorders. I am the medical director at Weill Cornell Medicine Headache Program. I have been treating headache disorders for about 13 years, and a lot of people wonder what headache is and how do you describe them. And actually, headache is just a term that we use that means pain in the head, headache, and it doesn't describe the actual diagnosis that different people may have, in the same way that a stomach ache just describes a symptom rather than a diagnosis. Headaches are very common. About 70% of people in their lifetime will experience a headache, with the most common one being tension-type headache. Tension type headache are typically mild to moderate featureless headaches, often not driving people to go to the doctor. The most common type of headache disorder that I see is migraine disorder. And migraine comes both with aura, which are neurological symptoms that precede the headache, or without aura, where people just get a pain syndrome. And migraine is extremely common disorder. It affects about 12% of the population, more common in women than men at a ratio of 3 to 1, so about 18% of women have migraine. It's often correlated to hormonal changes, which is certainly one of the factors that women experience migraine more than men. And for many people, the onset of menstruation in teen years can be the first time people start experiencing migraine headaches, and also in the perimenopausal and menopausal period, when there are many hormonal fluctuations, can be a time of worsening migraines. And migraine is defined by basically a moderate to severe headache where people have some sensitivity to either light or sound, which can be just very mild or very strong, or lose their appetite or even get nauseous or throw up. And attacks are usually longer lasting. Migraine, because of these associated symptoms and because of the pain, most people don't understand, or most people who don't have migraine don't realize that migraine is a very disabling condition. It's in fact the 6th most disabling condition globally in years lost to disability, and amongst women under 50, it's actually the 3rd most disabling disorder. But it's sort of this hidden disease, because when people have migraine, they don't have a cast on their arm, they don't have other visible signs apart from maybe a distracted look. So I think of it as this invisible disorder that affects so many people. And one of the things why it's so important to share information about migraine is that even though there are 35 to 40 million migraine sufferers in the United States, many of those people go undiagnosed, therefore undertreated or mistreated, and that leads to great disability. I also treat other headache disorders, cluster headache disorders, and a host of other primary headache disorders, and I look forward to answering your questions and helping you be more informed about these disorders, and it's my privilege and honor to be here with you today. Thank you.
Hi, I'm Heather Goodman. Thank you for having me. I'm a child and adolescent psychiatrist at Weill Cornell. I kind of do 2 different things in my job. Part of my job is I'm a consultant to the pediatrics department. So when kids come in and are admitted to the hospital for a whole variety of medical reasons, and there's any psychiatric issue that comes up, they'll call our team and I'll go see them. Oftentimes, as I was telling Anna before, because of sleep issues, or a lot of kids with comorbid neurological issues. And then I also have a private practice at Cornell where I see people, young kids, up to middle-aged and older adults. So sort of people at all different ends of development. So I get asked a lot about anxiety and depression. Those are probably 2 of the more common disorders that I treat both in kids and in adults. And I think something that's sort of relevant to all of us in the room is that anxiety disorders and mood disorders do tend to be a lot more common among women than men. I think about 10 to 15% of women from mid-20s to menopause will experience an episode of depression, which is about twice the amount of men. Similar statistics with anxiety disorders and with PTSD as well. We don't really know what sort of accounts for this gender gap. To sort of what Susan was talking about, we think hormones could certainly be at play. There are certain depressive disorders that are unique to women, depressive disorders that kind of come that sometimes we see more like right around menopause or before or after pregnancy. Then I think there's a whole other host of psychological factors and social factors, I think within our society as well, that we could talk a little bit more about, and I expect people might have some questions about. And then I think just quickly about stress and anxiety. I always say this to my patients, to kids and parents and adults. Stress and anxiety, they're kind of part of life, and I don't think stress necessarily has to be thought about as a bad thing. Anxiety is a physiologic state, right? Like if we didn't feel appropriately stressed or worried or anxious at times, we wouldn't get the things done that we all need to get done to be productive members of society. But I think sort of, it's being able to kind of learning how to channel it in productive ways, and then being able to distinguish when it becomes problematic, where it's interfering with your life, that seeing somebody professionally about it can be helpful. And that's something that we can certainly talk more about as well. So thank you for having me, and look forward to talking more about all these topics.
Perfect. Okay, so now we're going to take questions from all of you, and I just want to preface this. It would be unfair for them to answer any questions about your specific health problem, because your whole past medical history is very vast. So if you could just keep your questions more broad, that would be awesome. Okay. Yes.
Are there any new effective treatments for sleep apnea?
So the question was if there's any new effective treatments for sleep apnea.
So that's very important, because often we see sleep apnea, we think of CPAP equipment, right, and a mask. Mild conditions, which they are determined depending on the frequency of the respiratory abnormality and really the depth of the oxygen saturation levels at night. So if the oxygen drops significantly, we consider that more of a severe disease. But mild to moderate conditions can be treated effectively with oral appliances. And the idea of that would be to advance the jaw forward, because the tongue is actually inserted right on the chin. And what often happens when we lay on your back, the tongue falls backwards towards the spine, narrowing the airway. So if we can reposition the jaw with those oral appliances, sleep apnea can be very effectively treated. So that's the number one effective treatment that we have been focusing on. There are now new approaches on therapies that are having FDA approved as a rescue treatment for patients that have failed CPAP. One of them also focuses on the airway. It's a stimulator of the tongue muscle. So it's a bit of a pacemaker. It's tunnel under the skin, and it stimulates the tongue muscle when people go to sleep, protruding the tongue a little bit, so pushing the tongue forward a little bit at night, opening the airway as well. And whenever applicable, weight loss can actually significantly decrease the severity of the apnea, which will then lead to probably more treatment options being available for people to treat the condition. And just add one other piece, I'm sorry, sometimes sleep apnea can be exacerbated by body position. So if people have apnea only when they lay on their back, sometimes wearing a belt or a shirt that has either air pockets in the back or sometimes even a styrofoam that will keep you from laying on your back can be an effective treatment of sleep apnea. So we always have to personalize any condition to determine what would be the best treatment option.
How many hours of sleep is the ideal number of hours?
So the question was, what is the ideal amount of hours of sleep?
I'm glad you asked. I was going to add that to the introductions that we'll discuss later. It's very individual. So what we need to keep in mind is that the average is probably between 7 and 9 hours for most adults. As we get older, sleep becomes a little more fragmented, so it's harder for people to sleep sometimes 9 hours. And people may then nap during the day to catch up. But it's very individual as well. There's genetic basis, sometimes how much you sleep or what time of the day, if you're more of a morning lark or an evening owl person. And the other aspect is really depends on what you do during the day. If you do a lot of physical labor or mental work, you might need, or if you're sick, let's say, you might need to have more sleep during certain periods of time. Or during pregnancy, let's say, women need to sleep more. But in average, I would say 7 to 9 hours is the recommended amount.
Just on that, let's say you've been sleep deprived for a number of years. Can you reverse the effects of that in your life going forward?
So the question was, can you reverse sleep deprivation later in life?
As with most things, so the body is very resilient, right? So I think you can take a lot of insult. Let's say the same way I tell patients that there is no way you're ever going to be able to eat all the meals that you skipped in life. You're never going to be able to pay back all your sleep debt, right? But that's all good, right? So that's how the body functions. So you're very resilient and you're able to sustain some sleep loss. Now, if people have sustained very significant sleep loss, there might be deficits that can't be fully reversed. We don't yet know. I think we have a concern about that. And there's a lot of new science and new research in sleep that will help us have a good answer to that question. But I think we always need to be attentive to make sure to minimize our sleep loss, because as we get older again, we need to have that reserve kick in to be able to maintain adequate health and brain function.
Yes? Yeah. What is the name of the sleep center you mentioned that you work at?
Is the Center for Sleep Medicine,
Stanford?
Center for Sleep Medicine at Cornell.
And the other question, when you consider good sleep, does it have to be straight or can it be every 2 hours? You mentioned a nap.
So I'll jump in. So we're just talking about if it's okay for sleep to be fragmented or not, more or less. We tend to like sleep to be more consolidated. The reason being that chemically, sleep is not the same on your first 2 hours or the last 2 hours. As the night progresses, we go into different stages of sleep, and we have cycles which last about an hour, hour and a half. And at the end of each cycle, we have a different stage of sleep, which we call dream sleep. Some people call it deep sleep, but it's really not deep sleep. It's a sleep stage where the body is paralyzed in order to do a lot more processing of activities in the brain. And as the night goes on, each cycle of sleep ends with more and more dream sleep. So that's why we try to avoid sleep fragmentation as much as possible, because we change the chemistry of sleep.
When you talk about sleep fragmentation, does that mean getting up several times during the night and not being able to fall back asleep? Are there remedies for that?
Yes, there could be. So there are several items that we can do, lifestyle modifications. Again, if you go to sleep and your mind is very, very busy, you probably still experience sleep, but when you wake up, because of this fragmentation of sleep, parts of the brain are totally aware of the environment. And we need to figure out what is triggering that. So once we work to identify the potential triggers, we'll be able to help strengthen the sleep, let's say, to consolidate it. So there are remedies for that.
Is melatonin a remedy?
It can be one of the remedies, absolutely, because melatonin is secreted at night. It's a night signaling hormone for sleep, and the peak of melatonin is in the middle of the night. So if sleep gets to be very fragmented, if you're exposed to a lot of light stimulus can actually deplete the brain from producing melatonin. So sometimes melatonin supplementation can actually...
Take that, you take that regularly?
Yes, at low doses, we recommend that some patients should take that on a nightly basis. Yes, of course.
Does it matter if people work at night versus if you sleep at night or if you sleep, say, in the morning and the daytime? Does it affect the sleep?
The question was, does it matter if you sleep in the daytime or the nighttime?
It does, because we have a 24-hour rhythm in the body, and that's hormonally driven. The same way that melatonin is secreted at night, we follow this 24-hour cycle. We've been in this planet for long enough that the body has fully acclimated to the schedule of the sun and the darkness. So it's very important for us to be able to try to keep a very set schedule along the clock. And that's why many people suffer from jet lag, because you travel by airplane very quickly to a time zone that is very different from your own. So typically what I recommend is for people on the weekends perhaps, or to stay in bed perhaps for 1 extra hour at most, but not to shift more than that. For people that are night workers, it becomes a bit of a challenge because they want to function during the day, but they have to function at night when they work. So then we try to minimize some of the sleep changes by trying to overlap the sleep period with the other days that are the non-shift night days as much as possible. Even if it's just 2 or 3 hours of sleep cycle that overlaps with that schedule, I think that can be much better for the body to be able to sustain. If it is 1 night shift a month, then we try not to change with that. People would just unfortunately have to suffer through with that.
You spoke about the migraines and the hormones. Can you just speak a little bit more about that? Like if you're in, let's say in your 30s and you're tending to have more migraines, but I realize that you're having them during the onset of your cycle.
So the question was about hormones and how they relate to migraines.
Yeah, thank you for that question. Many women have hormonally related migraines. In fact, at least 60% of women have headaches around their menstrual cycle. And the studies show that those headaches tend to be stronger, last longer, have more associated symptoms, including nausea, are more disabling and harder to treat. And what I have seen, certainly the data seems to show that in the perimenopausal period, which can start as early as sort of the late 30s, where there starts to begin hormonal fluctuations, even before they're obvious to you, there can be subtle changes that they contribute to this onset of worsening migraines. So there's actually a second peak for women with migraines where they tend to get, particularly if they're hormonally related, worse in their 30s and 40s until that fluctuation starts to calm down. There are a number of different approaches to treating menstrually related migraine, and they sort of follow the same lines of treating migraine in general, which is basically that if you're having 2 or 4 or more migraines per month that are difficult to control by taking as-needed medicines, preventative approaches should be used, whether they are lifestyle changes, supplements, medications. There's a whole range of different ways that we can try to interfere or interrupt the process, that decreased threshold of getting more migraines. When we think about what migraines are and why they're triggered by hormonal changes, it's really the drop of estrogen before the onset of menstruation that seems to be the main trigger. So, for example, women who are taking triphasic oral contraceptive pills are having 3 times during their cycle where there's drops in estrogen, and that may not be the best option for it. A lot of my patients ask me about whether or not oral contraceptives are the right choice, and actually it's a very complex question to answer because they're certainly not without risk, and some women may get worse on them in terms of their migraine, and there are certain specific contraindications for migraine with aura for taking oral contraceptives. But there are certainly many supplements and prescription medications to use either preventatively or mini-preventatively right around the menstrual cycle, before and during, that can help reduce the severity and reduce the duration of those. Because they can be so debilitating, I would certainly work with your healthcare practitioner to target those and keep a diary over 3 months so that you can see when can you predict when they're coming. What are you taking? How effective is that? Is there nausea that's present that may need to be addressed for your pain medicine to work effectively? And also how they're affecting your life. And if you're not getting pathway on that, then you can see a neurologist or a headache specialist.
Any non-sleep questions, or is it all? Okay, all the way in the back. Yeah.
Yeah, I noticed in my 50s that my memory is declining, and it's worrying me, and I wanted to know, I've read that it's common after menopause or during menopause, but, I mean, what is normal and what is, like, something that would be concerning?
So the question was about the normalcy of memory loss as it relates to menopause.
It's very common, starting from that. So there are hormonal changes that can really predispose us to developing abnormalities in terms of our day-to-day functioning and memory and cognition. Although it's not a necessary finding on everybody that goes through menopause. So I often ask people to have it evaluated if you notice some memory declines, because we need to rule out that there aren't any underlying, from my perspective, sleep changes that are now fragmenting sleep and fragmenting REM sleep specifically, which is a period of sleep where there's a lot of memory consolidation, and we need adequate periods of REM sleep in order to maintain adequate cognition.
Yeah, and in addition to that, there are hormonal changes that lead to that cognitive change, and often it is fuzzy-headed, not being able to find a word quickly. But if you find that it's interfering with your activities, speaking to your healthcare provider to get a baseline in terms of an actual assessment of how good your memory is can be helpful. But also looking at all the factors, like you were saying, sleep, mood changes, depression, anxiety, all can trigger memory impairment.
start with primary care physician and go from there.
And also maybe bring with you sort of a diary of what the types of things, where the cognitive issues are, what difficulty you're having, and also are these other factors present, sleep, diet, anxiety, stress levels, and so forth, so that you can look at it from a whole component, not like, here's a pill, but try to pinpoint what the problem is.
Having a baseline is really helpful. So I think, yeah.
It's interesting, doctor, you mentioned that migraine is a hidden disability, and deafness is a hidden disability. We are not taken seriously of our disability. Oh, you'll get over it. Oh, it's just a headache, you're complaining too much, things like that. How does that affect the psychological aspect of this person?
So the question was about, and a very good question, especially for women, how patients can be taken seriously for some of these invisible illnesses and disorders.
Yeah, that's a great question. And historically, migraine was thought of a disease or disorder of hysterical women, right? And unfortunately, there's still some of that stigma that remains. Fortunately, the science of migraine has begun to catch up. So it means that we understand a lot more the pathophysiology or the underlying mechanisms of migraine in the brain, which helps us to say, no, this is a real disease, it's an inherited disorder. The other part of the challenge is not only the social isolation that people feel when they have migraine, but also sort of a sense of disempowerment that they can't really share what they're feeling or experiencing. And it also translates into a real lack of dollars going to research migraine. So despite the fact that migraine is more common than asthma and diabetes combined, in terms of what the NIH spends on migraine research, it's less than 1%, despite that 35 million Americans or 12% of the population suffer from it. So there's a systemic or an endemic issue in terms of migraine awareness, and it's very important. So what are we trying to do about that? One, there is a group of neurologists who go and patient advocates, and patients are all welcome to go to this thing called Headache on the Hill that's held once a year in Washington, where we go and we lobby our representatives to encourage them to increase support and sponsor certain bills. And that includes getting headache migraine as part of the Disability Act, which has not been the case so far. It's very challenging. So in terms of patients and their families, it's a big issue because a lot of people who live with people who don't have headaches or may know someone who they don't really get it. Educating your family and friends about the disorder can be very helpful. And that can be, one, referring them to websites like the National Headache Foundation or the American Headache Society, where they can learn about the disorders and appreciate what you're experiencing, as well as having your family member, your loved one, come with you to the doctor so they can understand and be educated by your physician.
And just to piggyback on that, I think something that we see a lot is patients who are demoralized, not necessarily depressed. I think the two can sometimes, I think sometimes people say depressed to also describe people who have an experience where they feel like they weren't heard or they're dealing with a serious medical illness, whatever it might be. And as a result of that, become down and feel isolated and not supported. And I think that's where sometimes patient support groups can be very helpful. Specifically for mental illness, there's an organization called NAMI, the National Alliance on Mental Illness, that has chapters around the country. There's a really strong chapter in New York City that all the services are free, and they have a lot of support groups for families and patients. So I think it's a really important point, and yeah.
Speaking to what you ladies were just chatting about, like the woman in the back about the fuzziness in the brain, I wanted to just take it a step further. I didn't know, because I have, I'm sure we all do, as we age, a lot of these same symptoms, and I didn't know
So the question was about how sleep additionally contributes to the mental fuzziness and how social drinking or alcohol in general can contribute to memory problems.
That's a great point, because I think what we often feel, there are even some cultural understandings that some people feel that culturally it's okay to drink to go to sleep. And we know there are some countries that this is very commonly seen. What happens with alcohol is that it is a sedative, so it's a chemical compound that gets into the brain. People may perceive that it might facilitate sleep onset, but once it gets metabolized, it breaks down sleep. So the net effect is negative on sleep quality. And worse than that, the worse as the alcohol is metabolized, it gets into the second half of sleep where you should be having more and more REM sleep. So now we speak about memory issues. If your REM sleep gets to be even more fragmented than it would be otherwise, it can have definitely a negative impact on memory and memory consolidation as well. So definitely we are very concerned about alcohol intake, the same way other exposures to nicotine, caffeine, which is also so widespread, can also fragment sleep and decrease the power of sleep in healing and allocating better memory consolidation for the night.
Yeah, the other aspect of alcohol is that it can deplete B12. And B12 is very important in memory over the years. And it's interesting that the new guidelines for alcohol limits have really been reduced to sort of 5 drinks a week for women. That above that can really create some adverse outcomes. So thinking about not only the way it affects sleep, but also nutritionally.
But yet, there are so many other scientific studies that talk about the health benefits of the glass of wine or at night. So how do you create that balance? What do you suggest?
Well, I think that I mean, it seems like the new guidelines are that 5 drinks per week should not be exceeded because it can have negative outcome on all areas of health.
I think to Dr. Broner's point, I think that's the most recent sort of in response to some of the earlier studies that you were talking about some of the benefits about having a glass of wine every day.
Right. And the other aspect of that is the Mediterranean diet, where people do drink more, is rich in antioxidants, which probably may counter some of that and may falsify the benefit of alcohol.
Yeah, so to that point really fast, because it's a common misconception. In medical school, we just learned this. So it's actually the other stuff in the red wine, and they've pinpointed like some South American red wine that has the best cardiovascular effects because of different vasodilators, but it is not the alcohol in the wine that is helpful. So I forget, but all the way in the back, yeah.
Thank you for this panel. It's excellent. My husband has his brother passed from Alzheimer's, and it always makes me worry, and he's in denial about even talking about it with his doctor. Are there any signs or symptoms or anything that I should look for, or any tests to encourage him to try to get, and can you slow it down?
So the question was, what signs and symptoms should you look for when you're at risk for Alzheimer's disease, and can you slow that process down?
That is, first of all, I'm sorry to hear that. It's a very difficult disease. Catching it early is difficult. It appears that that there are harbingers of it in mood changes in the 10 years preceding the onset. But also people can have mood changes anyway. So it's sort of like, oh yes, if you look back at this person, maybe we could have identified an issue. If there is a family history of Alzheimer's disease at an earlier age, he can, there are specialists in Alzheimer's disease who can screen you and even test you for genetic vulnerability. And also speak to you specifically about doing activities that help prevent dementia. I mean, when you get to, I think it's 50% of people over 85 have some form of dementia. It's 25 to 50% over 85. And I think most of us are looking for ways to improve our outcomes long term, in addition to reading about it, looking for signs and symptoms early and seeing if you're at personal risk for it. There's other risk factors for dementia. Those are anything that's a vascular risk factor, so high blood pressure, diabetes, high cholesterol, making sure that those are in control, and also exercise, social interactions, things that activate the mind, and even if you can combine those, like something like social dancing where you're doing a physical skill, it's social interactivity and it involves the frontal brain of executive planning, is there many good ways to try to be active to try to help minimize that. But I think it's a combination of different factors that help us reduce our risk of developing dementia or staving it off a bit. There is somebody at Weill Cornell who specializes who only sees patients who are asymptomatic, who do not have any symptoms of Alzheimer's, who do want to evaluate their risk for it, and I'm happy to share that information with you.
Do you know his name?
I will have to look that up for you. Oh, yes, yeah. Do you want to just tell them? Okay. There we go.
There is somebody,
It's
when you said you have to go to your primary doctors will say it's age. Your hospital has a special department.
Yes, there's an Alzheimer's department, and there's also Dr.
Richard Isaacson.
Right.
He does a lot of this Alzheimer.
Richard Isaacson at Cornell does the preventative and evaluating you and so forth, and then the whole team at Cornell, the Alzheimer's unit, is wonderful.
And I'll just add to this, the lifestyle modifications as well, just reinforce that for any health issues, right, the brain or physical, always focus on a good diet, exercise, make sure there are no vitamin deficiencies. Sometimes people actually overtake their supplements. We have to be careful with a lot of supplements. Sometimes people take vitamin Bs in excess, so we have the flip side of that as well. So I think having a primary care or generalist that can actually focus on this to understand how is your lifestyle is not just about one modification, but putting everything together.
And there's one more thing I'd like to add to that, which is depression can be part of Alzheimer's and dementia, but it also can mimic dementia. So being evaluated for mood disorders, I don't know if you want to speak to that, and getting them treated is also.
Yeah, and that's where there are general psychiatrists as well as geriatric psychiatrists who really have expertise in that evaluation, who see older patients who have both or one, and are good at sort of teasing that apart because it can be difficult to assess that.
Can we talk about just dealing with anxiety throughout your life and, having anxiety at a young age and kind of seeing that trajectory through your life? And does it mean you'll always have like an anxiety disorder, or how do you kind of prepare?
So the question was, could you speak a little bit more to anxiety and the trajectory for your entire life if you start out having anxiety at a young age?
So it's interesting. So kids, actually, boys and girls have similar rates of anxiety, and then we sort of see a change after adolescence and 20s and 30s that more women than men tend to at least report anxiety symptoms than men. But I see a lot of kids with anxiety disorders. It's probably one of the most common diagnoses among kids, that and ADHD. And there are a good proportion of children who have anxiety from a young age and will go on to outgrow it. I sort of think about it like I also sort of think about anxiety both as being like physiological, like I said before, it's there for a reason. And part of, I think, good treatment is sort of learning how to channel it productively. And then I think there are some people who just tend to run more anxious, and that doesn't necessarily go away, but the good news is that there's really good treatment for anxiety. We have a lot of data about treating anxiety disorders, and what we know is that a combination, typically, if it's really debilitating anxiety, of medication and therapy, specifically a type of therapy that really helps you kind of understand the anxiety, understand some of like the thinking traps that you can get into when you kind of tend to run more anxious, and how to challenge those and almost become your own therapist. So I always say to people in my practice who are anxious kids, and older adults. The goal is not to totally eradicate the anxiety, but it's sort of to hopefully quell it, and ultimately kind of become your own therapist, so you learn how to deal with it better and channel it more productively. But I really like treating anxiety because it's very treatable, and it doesn't have to be a debilitating disorder. I don't know if that totally answers your question.
So unfortunately, we only have a few minutes left. They will be available in the other room. I forget which number, but they'll repeat it for additional questions. But with these few minutes, I just want to ask you guys a question. What resource would you recommend to everyone once they leave this room and go forward so that they can adequately arm themselves with tools to go forward and tackle these issues?
From the sleep perspective, you can look into the National Sleep Foundation. It's a very helpful website. We have our own website as well that is being remodeled to be more patient-centered, I guess, and more informative. But it's up and running, has been for about 10 years. And you can just Google sleep medicine at Cornell. You'll be able to get into our website as well easily.
In terms of national resources, the National Headache Foundation is an excellent resource. It's a patient advocacy group that's centered in Chicago, and there's also the American Headache Society, which is the professional arm of headache doctors. So they represent physicians who are headache specialists, but they also have information there for patients with diagnosis sheets, diaries, and so forth, which are very good. We have our website, the Weill Cornell Medicine Headache Program. We're currently building and elaborating on that and hope to have even more information in the future.
So I think just for general information, the National Institute of Mental Health has a nice website that kind of has general overviews of a lot of different psychiatric disorders. As a resource for patients and families, I really like NAMI, the National Alliance on Mental Illness that I had mentioned before. And then at Cornell, there's the Weill Cornell Specialty Center that has a few different locations with psychiatrists who have expertise in sort of all different areas: reproductive psychiatrists, geriatric psychiatrists, child psychiatrists, general adult psychiatrists. And most of the major, pretty much all the major hospitals in the metropolitan area have psychiatric services. I know that they can be challenging and difficult to find. So if anybody has more specific questions about that, I'm happy to answer that after as well.
Awesome. So we're out of time, but thank you so much for coming. And in addition, the Stroke Prevention Center has a table set up in the screening room. So if you have additional questions about stroke prevention or stroke management specifically, you can go there. And again, they'll be available afterwards in a separate room for questions. Thank you, guys.